Hello and welcome to the Great Birth Rebellion podcast, where we grapple with current research to help you get the best out of your pregnancy, birth and postpartum journey while still challenging the dominant birth culture. I'm your host, Dr. Melanie Jackson at Melanie the Midwife, and I'm joined weekly by my co-host B from Core and Flora Store, and this is the Great Birth Rebellion. Welcome everybody to this week's episode of the Great Birth Rebellion. B and I are back with you, and today is part 2 of the episiotomy episode. So last week we started out the episode not entirely sure if we would be able to fit all of that information into one episode. And I feel like, B, you called it early. I was hopeful we might be able to fit it in, but no. So we are in part 2 now, which is important because episiotomy is big, which we discovered in the last episode. So if you haven't listened to last week's episode, part 1 of episiotomy, this definitely needs to be listened to together. So this is just a carry on from that. So we had already discussed how episiotomy was done, the issues with how they're done, the types and when, circumstances under which you might be offered an episiotomy. And now we're going to talk through women's experience of an episiotomy, including the consent process. We will run you through some advice on healthy recovery from an episiotomy, and also some tips on how to keep yourself safe from getting an unwanted episiotomy, or maybe what we will call an unnecessary episiotomy, not medically indicated. All right, let's kick off. Hi, B.
I'm here. I'm just yawning.
I know.
And nodding, and then I was like, they can't see you nod, B, like talk. But often our day is like go, 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 go. And then we get to this podcast and you take over and my nervous system goes, and lets out all the yawns. But yeah, I'm here. Hi, listeners. Thank you for turning up to this. Thank you for being here.
Please feel free to settle into this chat. If you just need to know that it's completely fine. We've both had a big week, but we're here. We love this. I love Tuesday, recording day. It feels good. It feels right, but it doesn't mean we're not tired. So
validating it all. All right, let's get into this. Thank you to everyone who shared the episode last week.
Yeah, there's been a lot of sharing. So women's experience of an episiotomy. We spoke a little bit about how this occurs and the external environment that goes on when you're having an episiotomy. It's not just a cut. There's a whole social structure around it and big feelings. So within that event of having an episiotomy, consent has to be sought from the woman. This is her body, and you're about to do something to her body that her body wouldn't normally do. So it's an intervention. It's a medical intervention. And we're required as clinicians to get explicit consent at the point where an intervention is going to occur. And so this is a legal, moral, and ethical journey to get consent. And one of the issues with maternity care at the moment is clinicians will say things like, I'm just going to go and consent the woman. I'm just going to go and get her consent, right? They're assuming that they're going to walk in, give you all of the information that they want you to have, and that you are going to say yes to that. Their thought, it doesn't really cross their mind that you would decline this intervention.
Oh, I think it depends on their experience with you. Because for some, they will, and that can actually be a hindrance because they're assuming your answer. And so if they already feel like you're going to say no, that will put them in a very different state. Like people will enter that room with very different energy based on their previous experiences with you. And I think here with consent is a really interesting one, like to think about how we've been raised with it, and then to think about what people empower, the cultural conditioning that we can have around this issue. Because, because we have that place of power, we think what we're going to give or do is right and wanted by everyone. And so often the people that hold these positions, like doctors and or midwives, have grown up in that world where real consent has never been asked for.
Mm.
It hasn't. Most of us haven't actually experienced that. We haven't experienced, even in our intimate relationships, but so often our bodies have been, I don't want to say under the ownership, but we often get treated like other people own our bodies. Parents, in intimate relationships, like there often is this subconscious acceptance that people can do things to you. And so I feel like it's so deeply cultural that most of us truly don't understand consent.
Mm.
And we have no idea that consent can be fluid. And so when we go into get consent, there's already, from years of cultural conditioning, a place that we do that from, and that place can be altered based on the person's different interactions. But yeah, if your care provider is holding themselves in a place of power rather than a place of equity, then they are going to often, unless they've interacted with you and have preconceived ideas based on previous evidence that you may say no, or they've actually read your birth map and know that you want to say no to this, and then that's going to affect it too. Like there's so much to this because we're just human beings.
Mm-hmm.
And I think when it comes to birth, that's the most important thing to think about, is that we're actually all turning up to your birth as humans.
Yeah. Well, and I think though, because they so genuinely believe, your clinician would only, I would hope, give you an episiotomy that they genuinely, wholeheartedly believe you need.
Even
And
if we have outlined reasons that enable you to think that you don't need them, right? Like people are always doing the very best they can with what they have. And this can be a hard thing to really understand if someone has done something to you that you didn't need or want. And you're allowed to have all the feelings around it. But no doctor or midwife, unless they were a complete psychopath that needs to be taken out of the system, no, and not allowed to do paid work because they're unwell. No doctor or midwife is walking into that room thinking, I'm going to do this just to hurt somebody or because I want to. Like there is a genuine, really strong belief that they think what they're doing is necessary.
yeah.
And you're allowed to disagree with that. And your midwife is allowed to disagree with that. And we're trying to encourage disagreement to that if there's no evidence for it.
Yeah. And then they go in and sort of go, right, I need to get this woman to think like me. That actually, when I go in, you're not seeking their permission. Often people go in with the intention of converting the woman to their way of thinking.
Yes, convincing.
Yeah. So they go in and they say, okay, here's what we want to do, and here's why we want to do it, and here's why we think it's the best option to do this, right? Instead of giving you actual information about all your options and asking you what you're willing to consent to, the whole consent process is about bringing you over to their way of thinking. And that's not true consent.
No, but it's tricky because that, like, if you think about the way we were raised with GPs and doctors and medicine is sold on they have the answers, you go to them for that. And this is the issue with putting pregnancy in this model of care in the first place, because medicine is set up for the doctors to have the answers, for them to give you the advice and for you to take it. But if you have had an episiotomy and you wonder why you said yes to it, that's because this is playing out. Actually, the cultural conditioning that somebody else knows best for your body and you're to listen to that over what you believe is very culturally conditioned in us.
The other thing it is, and this is what happens if you say no to something in the hospital, there's something, well, firstly, before I move on to that, to what I'm about to say next, is there is research, and I would actually recommend everybody read this research top to bottom. There's a paper in the resource folder called The Ethics of Consent During Labour and Birth, and it uses episiotomies And as an example, it's a full text version available in the resource folder. And it will talk much more eloquently about ethics than what B and I can do justice to it in this moment. But
in our tired state.
That's why I'd say we're trying. But what this paper discovered is that in most countries, and they had a look at various countries, in most countries, the rate of women receiving episiotomies that they didn't consent to or didn't even know that they had was 1 in 3. So about, in Australia, it's considered about 30 to 34% of women didn't consent to an episiotomy, and that's different depending on where you are in the country and in the world. But we just have to acknowledge that because an episiotomy is done in what feels like a time-sensitive time in the birth, then the full consent process isn't usually performed. And what we learned as well, I posted on social media about episiotomies, and so many women responded with stories about how they said, don't give me an episiotomy. And one doctor said, I didn't. And then she discovered that after the birth that she actually had been given an episiotomy. And so there's issues with consent. And then, so what I was about to say earlier is that if somebody in labor, if somebody asks you to consent to something and you don't choose the thing that they think you should have chosen, there is a formal escalation process that goes on in hospitals. This is like written in their policy. This is what you do. If a woman declines something, you escalate it, which means you tell the person who's next superior to you in the hierarchy that this woman's declined this thing that you wanted her to consent to. So then the assumption is made that whoever went in to speak to the woman earlier either didn't give all the information properly in a most convincing way, or the woman is genuinely declining and needs more pressure put on in order to consent. So the next person goes in, maybe it's the team leader, the midwifery team leader, or somebody senior to the other midwife, and repeats this process and says, right, we hear that, you're declining this. We really think you should have it. And then the woman would say, yep, I hear you. I just really don't want that thing.
So typically they'll say yes at that point.
Potentially,
unless you have listened to this and you're feeling, and this is where birth preparation is super important. It's understanding who you are and how you would respond in that moment. Because what's happening here is you've said no to mum, and now mum's gone and gotten dad. Yeah. And so you are no longer in your anchored, centered, powerful being to give birth. You are now in a childlike state. And your childlike state has been deeply conditioned through parenting, schooling, and the government to believe that if you don't follow orders, something bad's going to happen. And this is the state that most women give birth in, because they go into that good girl state of punishment and reward. And this is how we're spoken to. That is the convincing, right? If you don't do this, this will happen. Those conversations, that language is used in this. And so it is incredibly hard. And I just want to say, if you're listening to this and you did say no, and then it did happen, you did end up with episiotomy, it's not your fault. It's not that you didn't stand up for yourself or your baby in that moment. What you're dealing with there is years of not just your cultural conditioning, but intergenerational cultural conditioning. And it plays out for all of us, and it plays out massively when we're in a vulnerable position. And what's a vulnerable position? Naked, on your back, legs up in stirrups with somebody in a authoritative position standing over you. Yeah. And then this is why we have so much trauma over this experience for many of us, and why we self-blame. But yeah, let's go with the fact you've said no to dad. Because that's what it is. It's the next person, and then like the team leader, then the consultant. And so women often explain and will say, I just felt battered down. Like I felt like they beat me.
Well, this is the inbuilt process in a hospital. This process is built into their usual practice. If you say no to your initial care provider, they'll send in the next one, and then the next one, and then the next one. So this is the process of escalation, and it's the exact situation that wears women down, and it's unethical actually because consent is supposed to be gained without coercion, and I see this as a coercive practice. That's the whole idea. They're like, we'll get somebody who's more senior, who's more authoritative, who's more qualified, who's got more degrees, and then that way the woman
Get someone who's scarier and more powerful. And beautiful registrars and beautiful team leaders. I'm standing up for those people because often I've seen like the less equipped people be replaced with more equipped people. Actually, sometimes I will say that but it's luck of the draw. You never know what's coming in that door. Unless if you're a staff member, you may, but even if you're a staff member in a big hospital, you may not. And this is the reality.
Yeah, even your midwife who's looking after you, he says, look, I know you said no, and I just want you to know that in 2 minutes, a doctor's going to walk through the door and have the same conversation with you. I just want to let you know that. So midwives are aware that this is happening, and sometimes they have the foresight to say to the woman, I know we've had this conversation, but the next step is that this person's going to have the conversation with you again. And they'll prepare the woman and they'll say, you can still say no. You've already said no. We know that. So that's the midwife acknowledging that there's a process and is actually apologetic for it and trying to prepare you for what's coming.
Because in her role, she just really often wants to protect you and she doesn't like that this is happening, but also how tricky that is for the family when you have conflicting advice or energy from different care providers, and the different energies, the messages, the belief systems that are held in that room, and how the family has to navigate that. And you really just want to say, I'm sorry if that's happened to you.
Yeah. And if you've got the capability, you can opt out of this whole escalation system. You could say, right, I've heard you. I'm saying no. Write in my notes that I've declined and do not send another person in here to have this conversation with me. You can be really clear. Anytime somebody says to you, we want to do this, say, okay, this is my answer. Write it in the notes that I have declined and do not send another person in here to have this conversation with me.
And it's your most powerful tool is to say, write it in the notes. The other thing is people want to hear that you are confident in your decision. So your language is actually super important. So a word that I actually really love is willing. I'm no longer willing to speak about this. You can write that in the notes that I've declined to continue to discuss it because I've made the informed choice and I'm willing for you to write that in my notes. The notes enable them to say, we've done the right thing.
Yes.
We've done the thing as per our workplace and as per our standards of care, because that's what it comes back to. Is anyone going to get in trouble?
And the challenge with episiotomy is that it's not a slow burn decision. Like some things, say somebody wants to give you a vaginal exam, you're coming up to a routine time in your birth process where it's time. You've got time to have a discussion about vaginal exams and to decline it and to say these words. With an episiotomy, your clinician is often deciding in the moment and informing you that they want to do an episiotomy, or not even asking for permission. They might say, I'm going to do an episiotomy, okay? And that's their way of getting consent. And if you don't physically bat the scissors out of their hands, they assume that you've implied consent. So this is the thing with consent, is if it seems as though you've implied that you are consenting to this by not declining, they assume that you've agreed to this.
And I want to say I think some people listening a couple of minutes ago may be very confused when we talked about that you could have an episiotomy done to you and not know about it. This happens a lot, and it's not just episiotomy, it's also things. I had someone the other day at a birth debrief say, I only knew I had a rectal exam once I read it in my notes 10 months later. So if you're listening to this pregnant for probably the first time, wondering how that happens, there's multiple ways that it can happen. The first would be that there's anesthetic there. So, for example, an epidural. And so you actually can't feel things. The other is that because of pain or fear that you're disconnected from the body, which is often the case. And so things can be much harder to feel. The other thing is that everything can be hurting and you're in the moment, you've got a baby in your pelvis coming out of your vagina and you don't actually know what's what because it's such a big moment for the body and the mind and the spirit or your soul. And so actually it's very common to be like, well, was I cut? Did I tear? Did someone touch my anus? Did someone stick their finger in my anus? I don't even know because there's so much on board in that area. It's hard to differentiate. So just acknowledging that, I feel like we kind of skimmed over that and some people might be like, what? Hold up, hang on, how would I not know? But yeah, lots of people don't actually know what's happening around their vulva and anus because it can be hard to differentiate.
And so I guess let's move into, so this is the issue, is that about 1 in 3 women haven't consented to an episiotomy. So I'm going to skip over the recovery from episiotomy for now. We'll come back to it because it feels like it's a natural flow into how to keep yourself safe from getting an episiotomy. And firstly is to be thinking about episiotomy while you're pregnant, not in the time of birth, which is exactly what this episode is for. So if you listen to part 1 and part 2, you're pretty well prepared to make some decisions around how you feel about episiotomy and how to keep yourself safe. So if you've gotten an antenatal understanding, so during your pregnancy, an understanding of episiotomy, when it might happen, then you have some time to form your beliefs and thoughts about episiotomy, then you can put it on some kind of birth map or birth plan where and communicate this to your care provider. If you've got one that's going with you for the whole pregnancy and birth, you're in a much better position. But if you're about to meet the person who's going to be with you at birth only in that moment when you arrive to the hospital for birth, then if you put your expressed wishes about episiotomy in your birth map or your birth plan, or you can literally walk in and go, don't give me an episiotomy, boom, that's plenty as well, or whatever you want to tell them. Basically, antenatal preparation is the initial key to keeping yourself safe so that you don't have to have this whole thought process in the moment that you might be getting an episiotomy.
100%. I do want to say that, and again, just acknowledging that I see all the trauma. Yeah, people come to me with all the trauma. So I'm not seeing all the goods. I mean, I am hearing lots of good stuff with people writing to me all the time, but often people put things on paper and they think it's going to be read and respected, and that's not happening. And so people hand their birth map over and it gets put in the notes, but the 6 people who have walked through that door to care for you that day have not actually looked at it. Maybe one has, but maybe the rest haven't. And I want to say to the midwives listening to this, if you're listening to this, I don't actually need to tell you because you're already converted. It's probably colleagues who won't listen to this that need to hear it. It's your job to make everybody else aware of what's on that birth map. Unfortunately, if you don't have a care provider like that for you, caring for you, then it's your birth support person's role. It is not your job. Your job is to labour and give birth. The person you bring with you in the room that's their job to advocate. You've chosen a birth support person. They're meant to support you. And it is okay to acknowledge that the person you've chosen may not be up to it, and that's not their fault, but bring somebody else in. Bring somebody in who says, I am so confident and comfortable to say, hey, you haven't read the birth map, especially the part about episiotomy. Because this is what I'm seeing over and over again. People write it down and then nothing. But so much effort gets put into these birth maps and then they're not actually looked at if the people don't have continuity of care, or if their continuity of care person doesn't actually respect their wishes, or not respect, align with them, and just kind of pushes them off to the side. But if you do have someone following you through your care and you talk to them about it antenatally, be super curious and aware of how they respond and what they say in the moments, because that will provide you with a lot of information around whether they're aligned with where you're at or not.
Yeah. And just the process of creating the birth map puts you in a position where you have to learn and read and make a decision about what you want. So if you create your birth map or your birth plan with your support people, they're coming along on the journey and they're also understanding. And so if there's a moment where your clinician says, I need to give you an episiotomy, and then your support person is like, wait, we did this in the birth mapping or the birth planning process, and she said no to that. So it's also not up to the advocate to decide if that's a good idea or not. So some people, some supporters are like, oh, I didn't know if it was okay to decline or not. Actually, that's not your decision to make. Your only job is to advocate for this plan. You don't have to take over the decision-making process. You don't have to know if it was a good idea or not. All you have to know is how to help the woman get what she had wanted. And so, yeah, antenatal education, having it in your birth map, having good...
If you don't know what birth mapping is, we did an episode on that, so scroll back.
Yeah, and the map sort of lists out, it's not just like, don't give me an episiotomy. It's, I will have an episiotomy in these circumstances, but I will not have an episiotomy in these circumstances. So, you know, it's nuanced. It's not like a yes or no. It's just, you know, these are my thoughts around
it's accounting for the fact that birth actually can't be planned for.
No, and you're just kind of going, if this happens, then this. It's a flow chart, the map. It's like a flow chart.
Yeah. And there may be no instance where you're actually willing for an episiotomy, and that is okay too. But it's about writing that down and actually going, okay, when would I say yes? And then having your support people know, okay, this is a situation where she has said, or they have said they would say yes, or actually this is in the no.
Yeah. And even before antenatally, in terms of a timeline, if you want to keep yourself safe from an episiotomy, and sometimes this is how women choose their next birth, is based on the fact that they got an episiotomy in their first birth, is there are some care providers and models of care that's going to put you at less risk of having an episiotomy. And typically, they're midwifery-led models of care where you have your own midwife. So whether it's publicly funded home birth, privately funded home birth, midwifery group practice within a public hospital. Some obstetricians, if you have continuity of care with an obstetrician who's very respectful and will, you know, then maybe you can talk to them as well. But basically, if you are in a low intervention model of care, which is usually midwifery model of care, then you're at less risk of an episiotomy. So if that's your motivation and you think, right, this time I don't want an episiotomy, your least chance of having one would be with your very own midwife. And again, you'll have a lot less chance if you're not in a hospital of having an episiotomy.
Yeah. I think people can think MGP protects them from everything, but MGP just means you know your care provider. I think it protects you from a lot of things to a certain level, but often a lot of people can have grief of, I was in MGP and this still happened. It's because you're still birthing in the system. And, you know, that midwife works under that system, and it's huge, and just a lot of love to those midwives providing that care and having to work like that, where part of the work you do aligns and part of it doesn't, because I did that for so long. And it's like your work aligns in your little MGP team, and then you have to go into the system and it doesn't feel like it does. But yeah, 100%. And then I would add to that, really having somebody like a doula. I mean, it's everyone, get a doula, get a doula, get a doula, get a doula, especially if you're in fragmented care and your partner doesn't feel like they can advocate for you. And if you're a partner listening to this, please, you have that right to say that, I don't know if I'm capable of that in that moment. That's okay. This doesn't make you a bad person. It doesn't mean you do anything wrong. It doesn't mean you don't love your partner. It just means that you might not feel capable, and that's okay. 100%, I believe in you. I know you're capable, and your partner thinks you're capable. That's why they've chosen you as a support person. And you can totally rise up into your power for this one, because Mel's going to give you some really easy to follow steps in order to be an advocate. However, if you're not feeling capable, then there has to be that discussion of, I think then we should get a doula. And
yeah. Or if you've got a really robust friend who you know would be up for it.
Yes. Yes. Yeah, robust friend. Like go through your context list right now. Be like, who's my most robust friend? Who can come to it balanced. I often say that, like, have you got a cousin or a sister or a really great friend who is like, yeah, I'll advocate for you, babe, and that your partner gets along with, because that trio has to work in unison.
Well, and you can think through your friend list and people in your life who were like, mate, if I ever needed to, do a thing, but like, who your ride or die is, right?
Yeah, but they might not be appropriate at your birth either. That can be tricky. Like, yeah, 100% that person would stick up for me in that moment, but maybe you don't want them in your birth. Like, it's so tricky.
I know. So think about it. Think about it. If it's not a doula and it's not your partner, is there a person who you are like, mate, if they will not let anyone cut my perineum? And that could be their only job.
Number one question to a friend: would you stand up for my perineum and anus?
Yes.
If not, then maybe we can't be friends.
We can be friends, but you can't come to my birth because I need someone who's going to stand.
No, stop it. We all need friends that are willing to stand up for our perineum. Don't accept friendship from now on if that person doesn't care about your perineum and anus. I always say that. Good friends care about each other's anuses.
Yeah. I mean,
I've got your ass. Isn't that it? I've got your ass. Is that the term?
I've got your back. I've got your back.
Nah, it's definitely not got your back. It's definitely I've got your ass. Specifically your anus, I think. Why would they have your back? That doesn't make sense.
I've got your back because you can't have it yourself. Like, I've got your All right. Okay, we're off track. Okay,
that's fun though. That was a little bit of humor to a very sensitive, big subject.
Absolutely. Now, next thing you can do is basically they can't cut your perineum unless they have access to your perineum. And you can make sure they don't have access to your perineum. And you can, if they don't have access, they can't cut it, right? So
that's really tricky if your legs are already up in stirrups and you're having contractions.
Don't get up in stirrups. Okay. They also
most people are going to be offered an episiotomy, they're going to be in stirrups, Mel.
Well, this whole thing about keeping yourself safe for an episiotomy is do things to avoid getting yourself in that position in the first place. So
okay, let's talk about that, but then we need to talk about the fact that people are still going to be in that position through all their best efforts.
Okay, so best efforts. Here we go. If you are advocating for somebody in the birth space, the first thing you can do when you walk into the room is take the brakes off the bed and push it to one side of the room. Then raise it up as high as it goes and put all the bags that you bought for the birth on top of it. Then you say to the midwife, where are your mats and peanut balls and birth balls and bean bags and birth stools? We want all of those. Bring them in. Okay, so then you want to fill the rest of the space with other apparatus that will allow you to move around freely. All right. This is what your advocate is going to do. You, as the birthing woman, are just going to use that space that somebody else has very diligently set up for you. And this changes the whole dynamic, because if somebody wants to get you onto the bed, it's no longer like just get onto the bed, in inverted comments. It's a difficult journey to get back onto the bed because you got to move the bags, you got to drag the bed over. It takes a long time. So there's a lot of decision-making processes that need to occur in between you getting onto the bed and a lot of sort of practical steps. So you can reconfigure the room to make it so that you're going to be more comfortable and more likely to use upright or forward-leaning birth positions that don't involve you getting on your back in labor. And then if somebody wants to do a vaginal exam, for example, you can lie down on the mat on the floor, or if there's a convenient couch or something at the hospital in the room that you're in. So the first thing you can, sorry?
Now, the biggest thing that's going to stop people from being able to do that is CTGs. So most of the time people end up on the bed regardless of whether they want to be there or not because someone tells them to get on there because they need a CTG. And the reality is what you're talking about, people only have access to if they're considered low risk. And the modern reality is that everyone is being deemed as high risk at the moment. If you've got a baby in your uterus, holy guacamole, you're high risk. So go back and listen to the CTG episode if you haven't already, because that you really need a clear understanding in your birth map of when you'll be willing and when you're not willing to have a CTG, because that's probably the biggest thing that puts you on a bed. And it's probably the biggest intervention that chooses, I guess, which path you go on in terms of what you get to access in birth or not. I'm really conscious of setting people up for what they're not going to get, because what Mel and I are talking about, it could be really simple, but it's been more and more complicated, and people are finding themselves on their bed. So if you do find yourself on the bed, having your advocate, your support people get you off the bed and put it up high again is super important. And this is where feeling powerful in that space comes in, because most people won't just go in, push the bed to the side. That takes a badass energy to feel safe enough to do that. And most of us are very good girls and very good boys, and we only do what we're told to do if we're told to do it.
This will be the job of the friend who has your butt, right?
100%. It's yeah, your robust friend is going to do that. But just acknowledging that not everyone's going to take someone robust with them into the space.
And so, but this is the strategy, is you basically want to not give them access to your perineum. And so anything that involves you getting into a position where somebody has so much access that they can cut your perineum, you could make micro steps not to get there, just like it's micro steps for how you got there in the first place. And so upright birth positioning, forward leaning, even if you are on the bed, you can put the top up and sit it up like a chair and turn around and lean over it. They only can do an episiotomy with you on your back. And so if you're not on your back, you significantly reduce your chances of having an episiotomy. So I guess, factor that in.
Reducing the need for an epidural as well. So listening to the pain episode we did, ensuring that you've got good support, and watching my free antenatal classes to really get some pain management techniques in there and understand pain, because once you've had an epidural, you're on your back. But access to your perineum with an epidural is much easier.
Yes,
and
that's right.
Often there is that need to have the vacuum or forceps birth, which then increases your need too. And if you want to rewind on that, induction, which if you want to rewind on that, decreasing how many ultrasounds you have. Like, we're going backwards in the cascade of intervention, right? Like, to be able to walk into that birth room and push that bed to the side, you want your last ultrasound at 20 weeks. So there's no discussion on the size of the baby. You want to avoid induction to be able to do it. Like, it doesn't actually just start in spontaneous labor. It starts with the model of care you choose, the place of birth you have. They're your two biggest impacts on whether you're going to have an episiotomy or not. Straight away, we know that's statistical as well. So if you go into the hospital in early labor, which again is often impacted by your support person, how much support you have at home to enable you and your support people to feel safe at home, because often people go into hospital because their partners don't feel safe. So having someone that feels comfortable, like the robustness of this friend, needs to actually extend in. They're cool with you having pain, and they're cool with you having pain at home, and they don't feel like they need to do anything with it unless you ask for it. So it's everything that we talk about in this podcast comes down or impacts whether you're going to have an episiotomy or not.
Well, yeah, and whether or not you're going to be on a bed when you're laboring. And so avoiding the epidural, like you said, is another one. So every time you get yourself closer to the bed, you increase your risk of an episiotomy. Every time you lay down there for a vaginal exam and don't get up in time, there's just so many things.
Don't get up again.
Don't get up again. There's so many things that tether you to the bed, the CTG. And so it's about preventing it in the first place with antenatal education, putting yourself in the right care model, and all these other things. So if then you've gotten to the point where you're actually, oh man, I have found myself in this situation where I'm on a bed or I'm in stirrups or I've got an epidural and I know now they have access to my perineum. In these sort of circumstances, I've got a course, it's not live at the moment, but we talk about power strategies for how to advocate for yourself. And in that course, I talk about having some clear scripts. And having clear scripts is also a strategy for conflict resolution and all kinds of things, right? But you can apply it in this circumstance. So basically, this is something that you can practice or that your advocates or robust friend can practice as just not going to think about it again line. If they say something like, I'd like to give you an episiotomy, is that okay? Have a single few word sentence that you can say in response to that. So it could be, don't cut an episiotomy, I said no. Or I don't want an episiotomy, don't cut one. Or if you're an advocate, she doesn't want an episiotomy, you can't cut one. And
I think a really good one is, I do not consent to an episiotomy.
I do not consent.
That's super powerful. I do not consent to an episiotomy. You are not to give me one.
Right.
And if that feels scary as hell, like when I do birth preparation, we do this kind of stuff, right? It's like, practice it. Now, what does it feel like in your body? And some people are like, I can't even say those words. And that is great to know about yourself. That is not, there's no right or wrong here. And we want to always meet ourselves with compassion. But if you're like, oh, I can't even say those words, like, okay, that's where we know your baseline is. That doesn't mean you're going to be that way in birth, because if you're pregnant, say you're 34 weeks, you got another like 8 weeks to practice this. And so we want to actually practice saying these things to people we feel safe with, because most of us don't actually know how to say no, or we don't feel safe to say no, so we don't say it. So you actually have to practice this. So practice with your partner. Have a girlfriend ring you up and say, hey, can you just tell me over the phone, hey babe, I'm just going to cut an episiotomy, and you have to say that line. Like, if what I'm trying to say here is, if it doesn't feel safe for you now, it is sure as hell not going to feel safe for you in the moment. So yeah, you can have these scripts, but if every being of your body is like, oh, we're going to get in so much trouble if we say that, and it feels scared, then that's not going to feel good for you or be accessible for you more than anything in birth.
Yes. And the idea of the script is if you don't know what to say in response to, I'm going to give you an episiotomy, is that okay? If you don't know what to say during pregnancy when you're not on the spot, then will you know what to say in the moment when you're on the spot? So this is why I encourage people to have it scripted so that it can become like an automatic response. It's like anything. If you're doing a presentation for anything, something big, a conference or whatever, a work interview, something, you write it down and you practice it so that when you need to present in a stressful situation, you can.
If it doesn't feel safe, if you're not able to advocate for yourself in normal situations and advocacy feels scary, then you have a couple of choices here. Start practicing it, or bring someone in who it doesn't feel scary for, and you feel safe enough with them to say your no, because care providers want to hear the no from you. They don't want to hear it from your support people.
Yeah, that's right. And then it can even be just don't. You can just say one word, don't do that. Or the other thing is if that line of don't cut an episiotomy or I do not consent, if that doesn't work, you can always go the other angle and say, if you cut an episiotomy now, that's assault. That's the other frightening thing. And people go, whoa, actually, it is. If they cut an episiotomy without your consent, it's considered assault, regardless of whether or not this episiotomy is for your safety or for your well-being of your baby. If you say no, it's still assault. And this is what people argue against. They say, yeah, but the doctor did that because it was for your own good. It doesn't matter what the intention is. If they cut an episiotomy without you consenting, or if you say no, it's medical assault. It's against what we're allowed to do as healthcare providers. So you can put that out there. If it's getting too much, You say, if you cut an episiotomy now, that is assault.
It needs your permission to do it.
Well, it's a surgical intervention. It's surgical.
Yeah.
You would never perform surgery on somebody without their consent. It's not appropriate. And so, if you get to that point where you're being confronted with the possibility that this is going to happen, there are some phrases that can potentially keep you safe from that. So use them, have them scripted, practice them, and so that they become an automatic response. If you don't want an episiotomy and you're in a situation where you think, right, I'm here now, potentially you've got an epidural, potentially you're at the point where you're being talked to about vacuum or forceps, have that discussion. If they say we'd like to do vacuum or forceps, say, right, I am happy to have a vacuum or forceps, but I do not want to have an episiotomy. And so you be really clear and practice those scripts that you can write. And you can do this for everything, but today we're talking about episiotomy. So these are your episiotomy scripts. Coach your support people and your robust friend. And you can be really clear with your care provider when you walk in. If it's super important to you, say, whatever happens, I'm very determined not to have an episiotomy. So please, can you help me with that? And so, yeah, these are the ways that you can keep yourself safe from having an unwanted episiotomy. All right, that's my list on keeping yourself safe. Let's say you did end up having an episiotomy and you think, right, here I am with my episiotomy. What do I do now? I just want to chat very quickly, briefly, about how to recover from an episiotomy. We did talk about it a little bit in part 1, but also the 2 weeks before that when B and I did the episode on birth debriefing. Consider if you've had an episiotomy, that an episiotomy was an end stage to what could have been a complicated or unexpected situation. And so consider in your recovery planning birth debriefing. And sooner than that, the thing you really need to do after having an episiotomy is lay down and rest and reduce irritation on the wound. And what that includes is if you've got the possibility of actually laying on a towel or something to allow some what I would call free bleeding, where you don't have a pad rubbing on the episiotomy wound through the day, wash the wound area daily. So with you can spray it or use a peri bottle when you go to the toilet. Those are the initial.
Just water.
Water, yes, just water. I wouldn't add salt or anything else fancy. Some people add like calendula. You can do calendula teas and things like that, but water's completely fine. Just think about it as I'm looking after some stitches, right? And keeping it clean, avoiding things rubbing on it, managing pain so that you're not sitting there uncomfortable all the time. You can apply ice packs like we talked about with recovering from perineal stitches and perineal swelling. Ice packs can really help to reduce inflammation. You can use anti-inflammatory medications if you need to. So once it's healed, there is things that you can do that include pelvic floor exercises and scar massage. So consider those as your longer term healing strategies. But at the very early time, just remember you've had a surgical intervention, some kind of surgery. You need to rest. You need to lay down, prevent infection, prevent inflammation, and allow your body time to heal. And this would include keeping well nourished and hydrated as well, so you can avoid constipation and give your body all the nourishment that it needs to repair.
Can you hear me now?
Heaps better.
Okay, good, because I really wanted to say this bit. I work a lot with episiotomy scars when I do internal release. So I just want to say, firstly, 100% resting, allowing that space to recover beautifully. And then we want to get into gentle movements. You might want to do I'm just going to totally plug it, the Core and Floor Restore program, or join us for live classes. So I wouldn't just be squeezing the muscle aimlessly, like really just connecting. And then what can be really important later on down the track, and just acknowledging that a lot of people I work with often come to me because there are issues. Not everyone with an episiotomy has issues. Sometimes episiotomies feel really fine. They heal really well. They do really beautifully. Other times people have the other extreme, but for those people whose episiotomies don't feel good and there are big stories, and for people that have had either vaginal examinations or episiotomies happen to them without consent, there can be a lot of trauma that the body's holding there, and that can be remembered by the body in other experiences like intimacy, for example. So I have a lot of people that come to me where either the episiotomy or the moments of birth come back to them with intimacy and it doesn't feel right. And so there's a lot of trauma that the body's holding. The internal release work I do, there's people called Holistic Pelvic Care. They're registered as a trademark. You can check on my directory. I have lots of people on there, and that is very holistic. The way I do it is different to how I've been taught. I've kind of come up with my own way, and that is to hold the trauma as well. And so what I often find with episiotomies is the scar's actually really angry. The body is holding a lot of anger and grief in that area, and that is a part of healing. So if you come to this episode because you've had an episiotomy and you really want to understand it and support yourself, perhaps if you're having another birth, that can be, if it feels right for you, and it's not going to feel right for everyone. So what I say, some people are going to be like, nah, that's not for me. But if it feels like it's for you, that kind of work can be super important to release the tension being held by the body and the emotions being stored in that tension and the story being stored in that tension. Super important if that feels right for you. So just want to say that. Yeah. Sometimes I work with episiotomy scars and they're not angry. They're calm and they feel joyous because and often they're the scars that are related to an episiotomy that felt very necessary and wanted. So just knowing that there's a whole spectrum here and the recovery is really working on what feels right for you. I will also add something like cranial sacral osteopathy, or other allied health like chiro if that feels right for you, or physio if that feels better aligned to your needs, in working with the body to heal as well, given that it is surgery.
Yes. And the other thing, we forget that I don't forget, but because it's a cut, it can have a lot more bruising than a tear as well. And so that initial healing, consider things like oral dosing of arnica. You wouldn't put topical arnica on either, but that is a natural therapy that you can have while you're breastfeeding that will help reduce bruising. And so I think too, what would be a great episode, if you've had an episiotomy or if you're preparing to have one, who knows, but the perineal suturing episode that we did talks all about a lot of perineal healing strategies, and a lot of those can be applied to the process of having had an episiotomy as well.
Yeah.
All right, everybody. That's been this week's episode, part 2 of episiotomy. We got there, B. I've got your butt.
You are my best friend who's got my anus. For those that don't know, because Mel's probably done a beautiful job of editing this out, my internet's lost its perineum today. It's really lost it. It has not handled life at all, and has cut me out and kicked me out of the podcast and then brought me back in a really super slow motion. And Mel's just held it. She's totally my robust podcast friend. Hopefully you didn't hear any of it, but now you'll know why we're laughing. That's the backstory.
The other backstory is that B was actually locked out of her house half the day because there was asbestos removal going on. I had a 48-hour birth journey with a client this week. My husband is about to go for 3 days on a work trip, and so we literally carved out 1 single hour to record this episode for you guys. We showed up. I've got your butt, and we will see you all in the next episode of The Great Birth Rebellion. Bye, team.
Thanks for being here.
Thanks for listening with us today. Don't forget to subscribe to our podcast on your favourite podcast platform and join our mailing list at melaniethemidwife.com. Mel sends out weekly emails with access to all the evidence we use in this podcast. You can find out more about Mel at melaniethemidwife.com and find out more about me, Bea, at coreandflaw.com.au. We can't wait to bring you next week's episode of The Great Birth Rebellion. Yeah!
Yeah! All right.